So it's a great honor to welcome you, Mirko Onofre from Rona. He will give a talk regarding pancreas lesion. So Mirko, I'm very keen to hear to your next talk. So the time is to you, to your talk.
Hi there. Thank you for your kind presentation. And I will speak about the use of contrast ultrasound for the pancreas and what potential of this image measure we know very well now in the pancreatic cancer. I'd like to start from the end, and then I will present to you my classic presentation with the didactic cases. But the end means that we performed this study, was recently published, and just to have an idea, if the use of contrast is an additional cost, or we can have some benefit from the use from this activity-based cost analysis, as you can see here. So the final conclusion is that if we immediately use contrast after the detection of a lesion in the pancreas, we can better manage the lesion, because we can better understand if the lesion is a solid typical ductal adenocarcinoma. So with CT, we can do quite always all the need for this lesion, for the treatment, the staging. And if the lesion is cystic, we can move directly to MRI. And so in this case, we have a better idea that the lesion is a tumor by detecting small septa. And we know the contrast is very useful for that. So now we can do this evaluation of the use of contrast, and I'd like to start from this analysis. We have a multidisciplinary meeting for the pancreatic cancer, as in every hospital. You can see here that we performed an evaluation. We review the cases in from 1 year, and you can see that ultrasound is at the beginning of a problem of solid lesion in the pancreas in quite the majority of the cases. So ultrasound is the method that identify the problem at the beginning. Unfortunately, if we go deep in the results of this review, you can see that time to CT, in example, is sometimes very long. So because the ultrasound examination can be not so clear, the findings, but also the report sometimes. So just look the time to arrive to a high volume center such as our Pancreatic Institute in Verona, and sometimes it's absolutely too long for a pancreatic cancer. So remember, ultrasound is the first examination, and in example, this is a small nodule, hypoechoic and solid in the Mucinous process of the pancreas that was incidentally detected. So what we can do, what we can write in our report by using only ultrasound. Ultrasound is not so good for lesion characterization, but we are in a good condition from a technical point of view to detect cancer in the pancreas, even if small. Obviously, if the pancreatic area is well explorable by using ultrasound. Speaking about small lesion, this is a very important paper, because these are the real small lesion in the pancreas, solid, less than 1.5 cm. So you can see that malignancy was quite a little bit more than half of the diagnosis. So small means not benign in the pancreas. Pay attention to that. So we can use elastography, Doppler, but very important is directly the injection of contrast. This is a multi-parametric ultrasound study to the pancreas. And I don't want to go inside the use of contrast, but the contrast, you know, that is completely different in ultrasound in respect to CT and MR. So we can have for sure some better results in example, the study of vascularization of the lesion. And so this is the method. We need to see the gland first. If the gland is not visible, injection of contrast will not give us nothing more. So if the gland is visible and we identify something in the pancreas, so the ultrasound study is finished, we can use the contrast to characterize the lesion. And after the pancreatic study, always use the late phase to have a better staging of the liver, because we can detect some small lesion not visible during the conventional study. A lot of guidelines from the FSUB, and we have also the NETS guidelines for the use of image method for the study of neuroendocrine tumor. Inside the image method, we have also contrast enhanced ultrasound. And this is our Italian consensus guidelines for the use of for the workup and follow-up of cystic pancreatic neoplasms. And inside, once again, there is the use of contrast by using ultrasound. What about this is a new recommendation from the FSUM guidelines? And what about the characterization of solid pancreatic masses? You can see this is the typical appearance of the most important one, typical appearance of ductal adenocarcinoma. The lesion is markedly hypo after contrast medium injection. When you exclude this kind of pattern, you can think about other less frequent histology or kind of lesion histotype. In example, this is hyperechoic in respect, quite similar to the aorta. This is a neuroendocrine tumor. This lesion is iso to the rest of the pancreas, so we can exclude ductal adenocarcinoma. And finally, this was an autoimmune focal pancreatitis. This is a multi-center study with a pathological confirmation of the lesion. And once again, ductal adenocarcinoma was hypovascular in 90%. So immediate diagnosis of this lesion is possible during the same ultrasound examination. This is an example. You can see a lesion in the body of the pancreas with dilation of duct. The lesion incidentally finding, so asymptomatic. The lesion is markedly hypo, so typical ductal adenocarcinoma. We can fast move to a CT staging, and this patient was resected. You can see a very small lesion, N0, M0, so perfectly inside the pancreas, ductal adenocarcinoma with dilation of duct upstream. What about the correlation? So why I have to inject contrast and not move directly to CT? Because here you can see a perfect correlation with the CT, but sometimes this is not the results. Let me show you this paper. You can see this is a correlation with CEUS in respect to CT of ductal adenocarcinoma. And there is a bias. The bias is that inside was considered only lesion visible at ultrasound. So this is important. But however, if we correlate, if a lesion is visible and detected with ultrasound, we can use contrast and look if the lesion is small. You can see that there are no false negative results of CEUS, but we have 4 negative results of CT. What does it mean? This means that if lesion is small, can be isodense on CT. So if we moved from this ultrasound examination to this CT, you can see that the lesion is invisible. So the final report of this CT could be pancreas normal. So we trust to CT because it's with contrast and is an important examination. And these false negative results can be a disaster for the patient, for the management and the treatment for the patient. So in this paper, 30% of lesion ductal adenocarcinoma less than 2 cm were isodense on CT, so not visible. Ultrasound can detect cancer in the pancreas directly without contrast, because you have this kind of difference in impedance for ultrasound beams. So the lesion is quite always dark, markedly hypo. Then the lesion is this one, very small, no dilation of duct. The lesion is markedly hypo, but the results on CT is not the same. So from here to here, there is a lesion on ultrasound, nothing on CT. CT is completely negative, pancreas normal, but is not normal. There is a ductal adenocarcinoma, small, 1.5 cm. So we can understand why this lesion at CT is not typically hypovascular. The reason why is that you can see that the lesion is small, and the fibrotic changing, the desmoplastic reaction is not definitely really organized in the lesion. So the lesion is well vascularized and is isodense in respect to the pancreas, because we are using this kind of image method. The techniques on CEUS is completely different, and so the lesion will appear hypo, because we are studying with a blood pool only the vascular supply to the ductal adenocarcinoma. So this is another example. In next of the pancreas, you can see a nodule is very small, and the lesion is completely invisible, is here on CT, and the lesion was hypovascular, so hypoechoic on CEUS. I have to say another thing important that is very useful to perform examination, CT, MR, and so on before the drainage of the biliary tree, because we need to see, this is a case of small ductal adenocarcinoma, completely invisible on CT, but was detected with a simple ultrasound at the beginning of the story of this patient. So ductal adenocarcinoma again. Coming back to our incidental findings, so this is a clinical scenario. You can see that the lesion is small, very small, solid, and hypo. We prefer to inject contrast directly, and you can see here that the lesion is markedly hypovascular after contrast media injection. So typical appearance of ductal adenocarcinoma. CT staging immediately, and then the lesion is very small, ductal adenocarcinoma 1 cm in the Mucinous process of the pancreas. Just to see that, to show you that also we can use this image method to solve some problem, because we know that ductal adenocarcinoma can be isodense, so there is a dilation of duct, nothing here. So we want to be sure that there is a lesion or not. And look here, the lesion is well visible, solid, hypo. We also inject contrast, is typically hypo, and this is the resected specimen. The lesion is perfectly inside the pancreas once again, as you can see. Let me show you again that the lesion was not per se detectable on CT. The use of contrast does not add information for the local staging. So this is a lesion well detectable by using B mode, and the lesion is infiltrating the vein. So I inject contrast only to characterize the lesion. I inject contrast not only for characterizing the lesion, but also to stage the liver at the end. So this is the two tasks. This is the two aim of the injection of contrast. So this is an example lesion of the head of the pancreas with infiltration of superior mesenteric vein. Here it was proved during the resection. The injection is only to be sure to characterize this lesion after the detection that is markedly hypo, so ductal adenocarcinoma. For this reason, it is a flow chart. Sorry, is in Italian because it's in the Veneto, Verona, in Italy. We suggest the use of MRI directly if a lesion is detected below less than 2 cm. If there is no possibility to inject contrast, during the ultrasound examination, it's better to move directly to MR. And I will show you why, because this is a small lesion detected in the body of the pancreas. Once again, the CT is not completely clear, but the multi-parametric approach of MR can show us that there is a stenosis and the hypovascularity of these nodules, so with a restriction of the DWI, typical appearance of ductal adenocarcinoma. Look at this case, incredible, because the lesion is completely invisible in the body of the pancreas. But if you see the MRI, you can see that there is a stenosis and there is small lesion on the DWI. Look, the lesion was detected during ultrasound examination and characterized also as a ductal carcinoma by using contrast. So this is a fantastic examination that we can use in the first line at the beginning of the problem of this patient. And the resection was once again a T1 and 0 M0. Moving to neuroendocrine tumor, differently to ductal carcinoma, these lesions are small in this case because functionally this is an insulinoma, and the lesion is hypervascular. So we can characterize this nodule as endocrine, neuroendocrine, because it is hypervascular. Functioning or non-hyperfunctioning neuroendocrine tumor. This is an example of huge neuroendocrine tumor with a lot of Doppler signal, but also in the small one you can detect Doppler signal because the lesion, this kind of lesion, this histotype, is typically hypervascular after contrast video injection. Moving to another book of pancreatic pathology, that is the cystic lesion in the pancreas. So we have a pseudocystic lesion and we have the cystic tumor of the pancreas. Very easy to solve the problem of a pseudocystic lesion, because we can have pseudocystic lesion only if there is a story of acute pancreatitis or sign of chronic pancreatitis. So if not, the lesion is will be at the end a cystic tumor of the pancreas. To approach the lesion is better to divide the morphology, the profile. We have a microcystic and lobulated cystic one. So this is an example of a round lesion, unilocular, like a ball, I mean, and you can see septa inside. The septa are vascularized, and this is a Mucinous cystadenoma that is very important to diagnose because it's a premalignant lesion and need surgical evaluation. The correlation between contrast ultrasound and MR and the lesion is very good in the cystic tumor of the pancreas. So if there is no story of acute pancreatitis and chronic pancreatitis, this is incidental finding. CEUS will work to show us the presence of septa, as in this case. You can see here very small septa, well detectable, better than the V mode. So prove after resection again a Mucinous cystadenoma. Better results in respect to CT-MR sometimes, yes, and this is an example in the body of the pancreas, another lesion, CT, MR, and completely better evaluation of the inclusion, vascularization of septa in this, once again, Mucinous cystadenoma in the body of the pancreas. Look at these results. This is a surgical paper from my university, and you can see that the workup, preoperative workup, in our pancreatic center, the first examination that surgeons ask for detection, for confirmation of a cystic tumor is contrast ultrasound in my department. So different is the story of a lobulated microcystic lesion. This is a serous cystadenoma, but we need to know the relationship between this kind of lesion in respect to main pancreatic duct, and this is not possible by using ultrasound. So this is a tumor, lobulated microcystic, but if there is no communication, this is a serous cystadenoma. If there is a communication, this is an IPMN. So is not really useful use of contrast in this case. So in the clinical scenario of this small lesion, it's better to move directly to MR, and you can see a communication in this case, high PMN of the branch duct. Few slides to conclude. We can use contrast ultrasound to characterize an incidental finding or to solve some problem, as I told you during my presentation. And this is an example of enlargement of the head of the pancreas. The report can be very different, but it's important to use all our tools during our study, ultrasound study. So our ultrasound study will be really multi-parametric. And in fact, you can see with elastography, a stiff area that is really stiff with respect to the rest of the pancreas. No dilation of duct, or whether this area is markedly hypo after contrast window injection, and was an ductal adenocarcinoma at the end. This is a cystic lesion in the tail of the pancreas, simple because no septa, no nodules, no enhancement on CT. But in reality, you can see that there are septa inside, better visible on contrast ultrasound, confirmed on MRI, but here we are proving the vascularization, Mucinous cystadenoma, the perfect correlation after resection. And with these three books, I thank you very much for your kind attention.
Thank you very much for this interesting talk. Let me just briefly check if there are questions.
Yes, thank you.
As far as I can see, there are no questions.
Perfect.
Not yet.
Congratulations for your excellent talk. My question is about, you know, that we are scanning contrast enhanced ultrasound also by the surgeries interoperatively. And for this, you know, we have a combination for different kind of probes. I use normally a probe from 6 up to 9 megahertz because it is a little bit difficult to use higher resolution probes. Like up to now we have linear probes up to 40 megahertz. What is your experience? If we have to find a decision during a surgery, what would you say? What is the best frequency for linear scanning during operation procedures?
Thank you for your question. Fantastic question, very important. We are using intraoperative ultrasound very often, and we have different indication. If we are speaking about less frequent lesion, such as insulinoma or endocrine tumor, can be multiple. So we need to stage the pancreas inside the operating room. And to be honest, we use the high frequency, the high resolution probe, because we put together the results of ultrasound examination or ultrasound scanning to the palpation of the pancreas, and is enough to confirm the presence of insulinoma and to exclude the presence of other one before the resection. Coming to ductal adenocarcinoma, with ultrasound, normally I confirm the situation locally of the pancreas. The local staging very often is quite similar to the imaging before the surgical operation. The problem is the liver. Very often there are small lesions not detected during CT, less during MR, I have to say, because MR, in my opinion, is absolutely better for the liver staging in ductal adenocarcinoma. We never use contrast inside the operating room, to be honest, but the indication is for a confirmation of the absence of metastatic lesion in the liver. You can use for this indication the microconvex probe, because you need panoramic view, I mean, and also you need the megas to explore all the liver, because very often also this liver can be steatotic or into chemotherapy. So my suggestion is use of a microconvex for the liver if you want to add contrast. Otherwise, we use, in my experience, the high resolution probe, but you have to move along all the liver to be sure to cover all the organ to exclude the metastatic spread. And we perform this in every patient before the resection.
Many thanks. Last question from me. Look at this. You talked about that you could find small metastases. I have the same situation. We are scanning now. We have a decision that we have liver metastasis, and perhaps also we have a decision that the pancreas tumor is not resectable because the resolution is so high during intraoperative ultrasound. But then we have to find a decision. Do we perform radiofrequency ablation therapies for the liver metastasis, or do we find a decision also for the electroporation therapies of the pancreas cancer? What is your opinion? In my way, they often decided that we should decide to help for our patient. And they asked, okay, we switch operation surgery is not possible, but we could realize a position ablation therapies. It is also your opinion? Because it's hard. It is hard to we find more tumor lesions, but we are also able to use ultrasound high resolution to perform then treatments if the surgery is not possible.
Thank you. This is a very difficult questions. I have to say that we now ask for MR always before the resection of ductal carcinoma of the pancreas for the liver staging, and the correlation between MR and the ultrasound in the operating room is very good. So this means that every patient that arrive here with a CT staging will ask for additional MRI before the resection to be sure about the liver first. Second, I agree with you. If you are in the operating room and there are lesions in the liver, we felt that there is a failure of the radiology department for the staging. So it's very important, if it's possible, to do something for the patient. This something is not, however, well established nowadays in the community, in scientific community. So if the lesion is only one, we can discuss, but when you see one lesion, means that there can be also multiple in the liver, not visible. So if the problem is liver metastasis, sometimes, very often, quite always, I have to say, we decide to do nothing. If the problem is the local staging, and I have to say that technical, surgical, the surgery from a technical point of view nowadays is very aggressive, if you want, but we perform radiofrequency ablation or electroporation in the operating room. Thank you.
Many thanks for your answer. I think this is very important for the audience, and congratulations for your excellent work. I give to my co-chair, Isabel Wiesinger, and many thanks for all the speakers. Thank you.
Thank you.
Congratulations for the excellent work and research, and I will hope that you are fine during a hard time, and many thanks for a good ultrasound team today.
And thank you very much to the audience for your interest in contrast enhanced ultrasound, and we hope you learned something today, and we could infect you with our passion for contrast enhanced ultrasound, and we hope to talk to you again soon, or maybe see you in person, and wish you all the best. Stay healthy.
Thank you very much to all. I thank you. Bye.
Bye.